Now, aortic stenosis. What is aortic stenosis? This is obstruction at the level of the aortic valve. Aortic valve, anatomically, where it is placed? Between the left ventricle and the aorta. How many cusps this valve has? Usually has 3 cusps. Sometimes you have 2 cusps. That is bicuspid aortic valve. It's a congenital condition. What's the other name of these outlet valves? They are called semilunar valves. Now let's see the case history. This is a 60-year-old man evaluated for a heart murmur during a routine examination. He had no symptoms. He jogs regularly and has no cardiac symptoms. Examination reveals a grade 3 out of 6 late peaking systolic murmur at the base of the heart. Now, what are the possibilities if a patient has this sort of a murmur? Patient is asymptomatic, he is running regularly. What are the possibilities? Is it an illness or this is a functional murmur? Now, what are the possibilities? We have got an ejection systolic murmur at the base of the heart. What are the possibilities? Ejection systolic murmur would be coming from aortic stenosis. It will be coming from aortic sclerosis. And it may be a functional murmur produced by anemia. So we do not see that in history there is a mention of anemia. The patient is running normally, doesn't have any symptoms. Anemia is very less likely because patients who are anemic are going to have symptoms because of anemia. At least they will develop that shortness of breath. So this is possibly these two, aortic stenosis and aortic sclerosis. Now, what would you do now? What will you do now? Don't say we will go for an echo straight away. You further do the clinical examination and few things which are not mentioned, look for the presence of these features, if they are present or they are not present. ECG, chest X-ray and echo are our plan. The physicals, you see, examination show what do you expect? We presume that this is aortic stenosis. What do you expect on examination? What will happen to the pulses? Delayed carotid upstroke. What is this called? Pulsus parvus et tardis. So it's a slow rising pulse, parvus et tardis. Apex beat is sustained heaving apex beat. It is not shifted. When there is aortic stenosis, there is hypertrophy. Hypertrophy is always at the expense of the lumen. The heart does not dilate. When the heart starts failing, it will dilate. Otherwise, it will not dilate. So this will be a sustained heaving apex beat. Now, what we call sustained heaving apex beat, how we find this is sustained or this is not sustained. So you see what happens during systole. The heart contracts forcefully. The apex is lifted throughout the systole from first heart sound to the second heart sound. So this is called sustained heaving apex beat. This happens in aortic stenosis and chronic uncontrolled hypertension. Reversal of splitting and weaker S2. Why splitting is reversed and what is reverse splitting? How do you find it out that this is reverse splitting? Normally what happens? Second heart sound, the aortic valve closes first and then the pulmonic valve because the pressures are high on the left side. In aortic stenosis, the ejection is delayed. So the aortic valve closes after the pulmonic valves. Normally what happens, the pulmonic valve closes after the aortic valve. There is aortic valve closure and then there is pulmonic valve closure. In aortic stenosis, there is a delayed ejection because of the narrowing at the LV orifice. So the pulmonic valve closes first and then the aortic valve closes. So this is called reversal of splitting. How do we pick up the reversal of splitting? Normally the splitting widens during inspiration. In these patients, it widens during expiration. So this is reverse splitting. You may have an audible S4. Why the S4 is produced? When the atrium contracts against a stiff ventricle. So there is ventricular hypertrophy, so the atria contracts against a stiff ventricle, it produces a fourth heart sound. So you may find these things on physical examination. Now what do you expect in ECG? What will ECG show in this patient? Yes? So it may show LV hypertrophy. Left ventricular hypertrophy may be present. What else? There may be left atrial hypertrophy. When there is left ventricular hypertrophy, chances are there will be left atrial hypertrophy because there are high pressures in the left ventricle. So atria has to push against high pressures. Atria may enlarge as well, and you may have left axis deviation. So you may find these on ECG in this patient. Left bundle branch block, sometimes the left bundle is going close to the aortic valve, and if there is severe stenosis, there is sclerosis, left bundle may be involved, and there may be left bundle branch block. Chest radiograph, not really very specific or very diagnostic in case of aortic stenosis. The ascending aorta may be dilated slightly. The aortic knuckle is smaller. The heart size, you see, it's not big. So normal or enlarged cardiac silhouette, calcification of the aortic valve. There is dilatation and calcification in the ascending aorta. But we don't see much in this X-ray. You just see the aorta is slightly dilated. That's it. Now, echocardiography is the investigation of choice. What we would see in aortic stenosis in echo, there may be normal systolic function, there may be slight diastolic dysfunction. There may be valve calcification. It may tell us about the pressure gradient. It was 64 millimeters. Pressure gradient means the pressure across the aortic valve and the aorta, left ventricle and aorta. We can calculate the valve area. It was 0.72 centimeters. You can pick up associated pathologies on echo. For this patient, we did not have any. So this is the echo. You can see the LV cavity size and compare it with the RV cavity size. This is a thickened muscle around it. T, what is T? Transesophageal echo. That may be more useful if you want to see the orifice of the aortic valve, and particularly if you want to see vegetations. T may be more useful as compared to the transthoracic echocardiography. How do you do transesophageal echocardiography? It's an echo attached to the tip of an instrument like an endoscope. And we go into the esophagus, and since the heart is lying close to the esophagus, it's easier to see the aortic and mitral valve with this transesophageal echo. Now, how do we grade this aortic stenosis? How severe it is? The aortic area, valve area must be reduced to 1/4 of its normal size before significant changes in the circulation occur. So you remember mitral valve, even the mitral valve becomes very tight, then the patient starts having symptoms. So the heart can tolerate mild degrees of stenosis and mild degrees of regurgitation. There is no problem clinically to the patient. AS is graded based on the aortic valve area. Mild if it is more than 1.5 centimeters square, moderate between 1.5 to 1.1 centimeters, and severe if it is between 1 to 0.75 centimeters. Now, what are the causes of aortic stenosis? Yes? You can say it is congenital, bicuspid aortic stenosis. When you see patients, when you divide them age-wise. Patients who are younger, they tend to have bicuspid aortic valve as a cause of aortic stenosis. In a little later age group, you may have degenerative diseases. So rheumatic fever and degeneration of the aortic cusps, this is the most common. So degeneration is the most common. So you see the mitral stenosis comes in younger patients. Aortic stenosis comes in older patients. Similarly, aortic regurgitation is seen in relatively older patient as compared to mitral regurgitation. So mitral valve disease symptoms and problems, they come in younger age groups, and the aortic valve disease presents in the later age group. Obstructive vegetations, Paget's disease of the bone, SLE and RA. So these are different conditions in which you can see aortic stenosis, but what I see practically, this one and this one, they are more common. And when you've got rheumatic fever, it's not isolated aortic valve disease. In rheumatic fever, invariably mitral valve is involved to a certain extent. It may be predominantly mitral valve disease, or mitral valve disease may be present along with the aortic stenosis. So generally we do not see isolated aortic stenosis in rheumatic fever. Mitral valve is invariably involved. Radiation to the chest. Now, what are the symptoms, main symptoms of aortic stenosis? Our patient didn't have any symptoms. So what, yes? Dizziness or syncope, and chest pain, good, or shortness of breath. Patient remains asymptomatic until the area is quite a bit reduced. Cardinal symptoms are exertional dyspnea, exertional angina, and exertional syncope. So the patient usually do not have symptoms at rest. They tend to have symptoms with exercise. Why they have symptoms with exercise? Because there is a failure to increase cardiac output because of a fixed obstruction. So cardiac output does not increase. So the patient has symptoms. Now the exertional dyspnea occurs why? When there is high pressure in the LV, there is going to be high pressure in the LA. The LA has to push against a high pressure in the LV. So the LA pressure starts rising. The pulmonary veins do not have any valve. So the LA pressure is transmitted back into the pulmonary veins. So when the pulmonary vessels, venous pressure starts rising, the pulmonary arterial pressure will also start rising. Basically, the pulmonary capillary wedge pressure starts rising and the lung compliance starts decreasing. Whenever there is congestion in the lungs, the lung compliance decreases, and the work of breathing becomes more and more. So the patient starts developing symptoms. Now, why the patients have exertional angina? It usually develops in the later part of the disease and reflect an imbalance between the augmented myocardial oxygen requirement and reduced oxygen availability because the cardiac output cannot be increased. And what is the other reason? But this is about angina, it's not about the cerebral vessels. Because there is a very high tone of the muscle, so the blood vessels are squeezed during systole. So practically no blood goes during systole into the coronaries. Usually the coronary filling is in diastole. But in this case, patient has very high systolic pressures, and at the same time the cardiac output cannot increase. So these patients tend to have angina because there is low cardiac output. When there is diastole, the blood will not be coming back into the coronary arteries. You know how the coronary arteries are filled? When there is ejection into the aorta, the heart relaxes during diastole, the blood comes back and goes into the coronaries. So there is coronary filling during diastole. Since the cardiac output is decreased in these patients, so the coronary filling will also be decreased. They do not have any blood during systole, and in diastole even the blood is decreased. So when there is tachycardia, there is exercise-induced tachycardia, the coronary filling is further compromised and patient has angina even in the presence of normal coronary arteries. So this is one condition in which the patients can have angina in the presence of normal coronary arteries. What is the other condition in which you can have angina with a normal coronary angiogram? Yes? Syndrome X, small vessel disease, the capillary are at fault. Exertional syncope occurs for the same rhythm. Patient, for the same reason, patient may have arrhythmias because of the exercise, usually ventricular tachycardia and sometimes bradycardias. There is hypotension and decreased cerebral perfusion resulting from increased blood flow to exercising muscles without compensatory rise in cardiac output. When you exercise, there is vasodilatation in the muscles. So cardiac output increases. In these patients, cardiac output cannot increase. So muscle goes into the blood goes into the exercising muscles. So less blood goes to the brain stem. So patient can have syncope. How will you treat this patient? What will you do with this patient we saw on a 60-year-old man who's been running with a murmur? Probably do nothing. Patient is asymptomatic, we'll be doing nothing. We're just following the patient. Asymptomatic patient requires no treatment. Medical treatment has no role in preventing the progression of disease process. With the onset of LV dysfunction, some inotropic agent may be advocated. Otherwise, medical treatment practically has no role in patients who've got aortic stenosis. Now, follow up this patient. The patient starts complaining of exertional chest pain 5 years after the initial presentation. What will be your line of action now? What will you do? Started having pain now. Yes? You will do dobutamine echocardiography. Why do you want to do dobutamine echocardiography? We want to see the reversibility, to predict the reversibility of LV dysfunction after aortic valve replacement. How much reversibility is there? Patients with LV dysfunction and relatively low gradients have better outcomes when management decisions are based on the results of dobutamine echocardiography. So when there is low gradient with LV dysfunction, the outcome is better. So we will go for a dobutamine echocardiography. When we do a cardiac catheterization in these patients, since this patient is complaining of chest pain, so you're suspecting that there may not be associated coronary artery disease. So you go for an angiogram to evaluate the coronaries in patient at risk for coronary artery disease, because if we are planning AVR, aortic valve replacement, at the same time we can consider cabbage. We are going to open the chest. If the patient has abnormal coronaries, at the same time you can do the coronary artery bypass grafting as well. So indications for cardiac catheterization are: if there is discrepancy between the clinical picture and echocardiographic findings, it means something is being missed clinically or on echo. So you want a catheter studies now if there's a discrepancy between clinical picture and echocardiography. Young asymptomatic patient with non-calcific congenital AS, to define the severity of obstruction to the LV outflow, you may need an angiogram in younger subjects. To evaluate for the presence of sub or supravalvular obstruction. Obstruction may be subvalvular, it may be supravalvular, it may be valvular. So there may be web in the aorta causing obstruction, or there may be a muscle mantle beneath the valve that may be causing obstruction. So you need an angiogram. And finally, if we suspect that there is coexisting coronary artery disease. So these are 4 indications in which we will go for cardiac catheterization in a case of aortic stenosis. Otherwise, it's not required. Management is surgical. AVR is indicated for all symptomatic patients. AVR improves survival in patients with depressed as well as normal LV function. So if a patient has symptoms, patient does not have symptoms, AVR may be useful on the criteria we saw. How is the echo, how is the angiogram, patient has symptoms or no symptoms, AVR may be useful. The risk of surgery in prosthetic valve complications outweigh the benefits of valve replacements. So in preventing cardiac death, sudden cardiac death. So this is useful. Now what are the different type of valves which are used? Maybe bioprosthetic valves, mechanical valve, or they may be homograft. So this is a porcine valve, and this is a metallic prosthetic valve, St. Jude type. So this is what we have, we can offer our patient. So our patient, when he started having symptom, you will go for now dobutamine studies, the catheter studies, and we'll go probably one of these options, whatever is available.